Hello and welcome. My name's James. I'm one of the Roses in the Ocean facilitators, and I am here with Will. Will, introduce yourself, please.
Afternoon, my name is William. I'm one of the facilitators on the project here with Roses. I've been working in the space for about 10 years, both through design, suicide prevention, and also with the experience of suicidality myself. So really excited by the project, really passionate, and I'd like to thank everybody for welcoming us into the Far West community to work with you on designing an alternative safe space.
Thanks, Will. Exactly what we're here to do is to give some of that feedback from the health professional conversations we've had around that co-design of Far West LHD safe space. So thank you for that. Let's do some quick acknowledgements. In particular, acknowledge the traditional owners of the lands of which we meet all here today and pay our respects to their elders past, present and emerging. And we acknowledge the Bakanji people in that respect. Also like to extend that acknowledgement of lived experience for those who have considered ending their lives and or attempted to do so, but also recognise that have lost people through to suicide, and acknowledge the magnificent lives that we have lost, but also those that are struggling in life today. So today we are about giving, as mentioned, a fair bit of feedback in terms of the conversation we've had to date. And in doing so, I will share with you that slide, if it popped up. It hasn't. No, it hasn't. Just bear with us. Oh, there's a little bit of a technical hiccup.
2020 strikes again.
That we haven't experienced before. I love a bit of something new. That is really bubbling around. So, there we go. Can you see that, Will?
Not as yet, no. Maybe just try sharing it again. There we are.
Yeah,
yep. Perfect.
Great. Yeah, so let's just quick process as in terms of where we're up to. We've shared the orientation webinar for those that have had an opportunity to see that, and the information pack that supported that. We've had a conversation with the lived experience focus group in terms of some of the findings there and their conversations and or feelings, and we'll touch in on some of those briefly as well. But also the health professional focus group, we've had that conversation as well. The lived experience co-design session was around 4 hours of fantastic feedback and ideas that came from that group. And today is an opportunity to give that feedback from those conversations. In particular, provide a bit of context of the co-design process. Make sure that we've captured what has been shared during the initial co-design sessions and gather the broader view and experiences, explore what's missing and help prepare for the next stage of the co-design process. And you can see a little diagram there in terms of where we're up to on that process. Is there anything you need to add there, Will?
Nothing in particular. Maybe just, first of all, welcome to all the attendees that have joined in. Great to see some of the familiar names again. As well as this process, as a quick refresher. So some of you may have actually been through this yourselves. So what I'm telling you is really just a reminder. Anybody who is viewing the webinar who hasn't been through this process, what's the key things to understand is that this is a co-design process. So within this LHD, as with all of us within this wide-reaching project of 20 different LHDs, to design that safe space, it is really about who in the community has that voice, who can participate in that. So that required us coming to the community and saying, who would like to participate? We had a number of people put their hands up, both in the experience capacity and the health professionals capacity. We then held a number of workshops with that cohort in individual groups before bringing them together into one combined 4-hour session where we started to actually look at the needs and ideas for those safe space. I really want to thank everybody who has been in that process. It is quite in depth. There's a lot of sometimes seemingly obvious questions from James and myself to prompt you and facilitate you along that process. But you've all been very, very generous and very giving with your time and your insights and plumbing your experiences to inform this process. That really is the foundation for what's moving forward. And we'll get into that in a bit. Today, we're covering off what you've told us, but the key objective in that first component of this project is to understand what are your experiences? How did that make you feel in a particular experience within an ED as somebody who is in suicidal distress? How did that contribute to that experience? What are the needs from that? And then how might we actually solve that in a future safe space? So a lot of work yet to come, which we'll get to at the end. But the process so far, a lot of work already undertaken and some really, really great insights that we'll be going through today.
Great, thanks, Will. And you're right. So thoughts, needs, and sort of our next steps is absolutely what we're about. See if this works for us. Oh, that's where we're up to there, that little that diagram there. So let's push forward. In terms of perspectives, we'll just mention that briefly, just the activities with the health professionals so far. And these are some of the diverse range of perspectives we've got from names, not necessary, but at this stage, certainly the titles of those roles, from coordinators, Aboriginal trainee, engagement manager, operations manager, towards zero suicides, care coordinator, Mission Australia, Royal Flying Doctor Service, mental health manager, and mental health clinician. So the conversations we've had with a broad group of individuals.
One quick note on that too, James, before we move on. I think that slide there, yeah, is a really, really good indication of the breadth of perspective that we did have. It's really, really important for a co-design process that we do have a lot of different voices and perspectives and opinions on the process. One thing that was really apparent in working with the health professionals was just how much passion and respect they have for the services that are there and the service that they do provide. But equally, a strong passion and a real desire to see alternatives and to see something that is designed by those in need, be those who understand the system that will provide an alternative safe space in the future. And so it was a real blessing for us, I suppose, in this project to have such a diverse range of experiences. It's really, really helped inform the richness of the content you'll see today.
Yeah, it's great. I think there was a common theme from a number of those practitioners or individuals that said this is about making only further products better as opposed to criticising what's already in place. So I thought that was a pretty powerful statement made. So this was about the feelings, the needs, and the kind of the blue sky ideas. And we went through that idea of, as a health professional, what does that look like? What were some of those feelings of supporting somebody through a suicidal crisis at the ED? And in fact, we actually used the stages of that idea of finding the ED or the access to, arriving, and the initial assessment and or a triage approach that was provided. That waiting period for individuals, again, so from the eyes of the health professional watching someone that they might have brought in or was actually in that waiting scenario. And of course, the treatment and or management while those individuals were there, and that departure process or leaving the ED. So in the next couple of slides, we're going to be highlighting some of those key points of discussion from that first phase. And everything that was shared in the conversation had been captured with the most common themes shown here. So let's jump into it, because lots to get through. There's that understanding of walking through or walking in the shoes of health professionals. So the findings, the idea of how do you actually access or get to that ED? A lot of health professionals that we spoke to, these were the feelings that they had, that concept of frustrated, concern, a sense of failure, a sense of sadness, disappointment, empowered when empowering others, which was probably a positive there, a little bit confused, guilt, anxiety, shame that things could be better, and a sense of mixed emotions, I think was a good summary there. Health professionals reported or spoke to us that people are reluctant to go to the ED for various reasons, particularly relating to a sense of lack of trust, uncertainty around how they will be treated, their uncertainty. Someone they know has had a negative experience. ED is easy to find and has multiple access points, including calling 000. And there is an uncertainty around the patient's safety if they go to ED, but at least have some level of safety. So at least it exists, but there was that sense of there was an uncertainty around that. ED may not be the best place for people in a suicidal crisis, and we'll explore that a little bit further as we go on. Some of the direct quotes or comments that were made were people just don't have suicidal thoughts during business hours. And I think that was a common theme, wasn't it, Will, that came coming through, this idea of it couldn't be between 10 and say 2 in the afternoon. In fact, there's no necessary time associated. People have mixed opinions about going to ED. Many people don't want to go in the first place. I want to make sure that they'll be safe and not sure if this will be the case. I feel lack of compassion will be shown in the emergency department, that the interactions won't be right, in fact, the wrong body language. Knowing that you have the knowledge to help, but there are a lot of unknowns about what happens once you arrive. So some direct quotes there from. So moving into that next stage, so the arrival and the initial assessment stage, health professionals feel through this frustrated, echoing of emotions between everyone, vulnerable, anxious, concerned, disempowered, disappointed, nervous, overwhelmed, and satisfaction yet to be helping was positive. The professionals reported ED is not welcoming or approachable, particularly for people who are repeat visitors and are treated not as an emergency. That idea of repeat visitors came through. There are instances where someone has been turned away and then unfortunately suicided. The ED triage process is not private or confidential at all, and anyone can see or hear what the patient is saying. Triage prioritisation leads to mental health related presentations being treated as non-urgent. Some people may not want to really find help, which is difficult for clinicians who want to jump in and help. And ED has Indigenous workers on rotation, but not everyone has access to the same support. So some of the direct comments fed back to us were experience depends on the vocalisation of distress of consumer. Don't feel a sense of relief when they're with the mental health team. It's terrible. Everyone can hear everything. Others are looking on, those that are bored. People don't want to disclose that info in front of a whole lot of people. Often there'll be enough service during business hours, but support drops off after hours. And walking through that door is the hardest thing I ever had to do.
One note, just quickly, James, I think it might be important. For anybody who hasn't been through this process, you'll see that those emotions are described, how I feel on the left hand there. Those are emotions, some really, really powerful statements from the participants, and that was how they felt in that situation. And so as we talk through this experience and this journey of every step, the health professional participants were really describing a situation where they were there and assisting somebody to access ED, but these emotions are how they were feeling in that moment, which is a really important lens to view this through, because we do want to make sure that the experience of the health professional themselves is also considered as part of this process. When they're describing situations on the right, so they reported that the triage process is not private or confidential, that's a really important observation on behalf of who they are supporting in that role. So how they were feeling, but also what they're observing in the situation.
Yeah, well said, thanks for pointing that out. What's happening there? Okay, I'm not sure why subtitles have popped up. Just see if I can take those off. There we go.
There we go. I didn't know that until now. There we go.
So treatment, we're up to treatment. This idea of health professionals, what they felt, the deflation, a level of frustration, uncertainty, helplessness and concern. And in that treatment space or management, I think was some of the conversation that came through as that been described. Reported concerns of lack of clarity and consistency around how to treat mental health patients in the ED. The idea of support drops off after hours, that's available. Not sure how to deal with the lack of resources which limit ability to provide adequate care to patients, e.g. a bed for admission. And health professionals feel as though they cannot do more in the ED and would have to step outside of their role to provide required level of care. The mental health ED service offering lacks cultural sensitivity was some of the feedback that we received. And what does that look like in terms of some of those direct comments? People don't always get to explain their narrative and articulate what they need. Need for cultural competency. Very few Indigenous workers and support. I need to ask myself whether I step outside my role to provide what's needed. I don't think that patients could safely stay in ED. Lack of consistency, much less clarity about process for mental health than physical issues. You can't put the same marble in the system and expect it to come out the same place, which I thought was a great comment. Outcomes aren't always achieved, can't do more, and resources might not be available, but what's the alternative to ensure safety? So the final part is that departure process in terms of that journey we walked through, and some of the health professionals felt, again, disappointed, frustrated, a bit of anger, self-judgment, inadequacy, guilt and uncertainty. Reported significant uncertainty as to whether ED care for mental health patients is appropriate and comprehensive enough. Lack of consistency around how to treat these patients. Limited follow-up, no clear framework for next steps. Patients so frustrated by the system that they discharge prematurely, whereby reducing opportunities for treatment. I think that conversation was around the timing associated, and the feeling that they were going through was a lack of support. And weekend support is not appropriate, be it highly clinical. Before we move on, are you happy with anything else there, Will? In terms of those comments?
I think that's great. I'm just wondering, maybe you could jump back to arrival and waiting. We may have skipped that. We can just quickly show the slides. The recording will capture all this, and to all the participants, you'll have an access to recording of this afterwards. So if we have breezed through anything and haven't read everything out, you can always look over the recording. That's always there. So yeah, if we could just step through those quickly.
That one.
Some of the quotes. And I think that we had covered waiting, so we should be all up to date. So there's quite a lot of content there, and as James has been reading out, we captured a lot of really interesting and insightful information about how you were feeling, as well as the reasons why that would be. And then we moved on to what your needs would be.
So happy for you to jump onto that part now, Will, if you like.
You get a sip of water, so and I'll take over. I got to stay hydrated. So really great foundation to look at what is the current experience of somebody as a health professional within the situation of somebody in a suicidal crisis accessing an ED. And it's a really important step because it allows us to narrow our focus to, well, what is the friction points? What are the areas that could be improved or could be designed differently to achieve a better outcome? From there, we asked, well, what's missing from services available in our region? One really important note that was brought up was consistent after-hours support. This reflects one of the earlier quotes that we saw about suicidal crises don't just happen during business hours, and that needs to have a service available after business hours or as much time coverage as possible, resources permitting. Adequate support for Indigenous customers, a sense of holistic care, and trust that the system is there to support you. Interestingly, alternatives to ED was brought up, which was great and very fortunate given that is the project. And I think it was really key that we did hear a lot about the human interaction and that support and that level of connection in who you're interacting with in an alternative safe space.
Yeah, great. Thank you, Will. Are we capturing some of the questions that might be coming through as well? We might do that at the end of this session, just in case. I saw a couple of those pop in. So moving on to, what do you need to feel comfortable with supporting people to access a safe space? And some of the feedback that we got was trust in the system will support the person in need. A lot of conversation around that trust. Having options to inform patients of alternative services. Patient has choice and control around that process. Engaging volunteers with a lived experience of suicide, and a place that can solve immediate crisis, that idea of support. Person-centred approach, consistency of support, peer-led with clinical support. The location is somewhere undaunting, to access this idea of a cafe or a haven, but certainly that feel for that. Simple information provided, coverage for after hours, and maybe it's 24/7 support. A sense that patients can talk to someone right away, and a space where people are listened to, validated and heard. So that's the feedback from us, and the next steps are the survey itself. So comments, questions, ideas around some of the data and information that we've sent back in this session.
And James, I think we do have time to open to any Q&As. We do have a number of participants in the webinar right now. So if you are joining us today, I do recognise some of the names, some I don't, so nice to meet you if we haven't met before. There is a Q&A button on the bottom of your screen. So if you do have any particular questions, you can click that button, type a question in there, and we can answer that for you now if we can. And otherwise, we can come back to you promptly with an answer. There is also that survey link, which we'll be sending out, and we'd encourage everybody to participate in. I might just allow a couple of minutes for any questions, should there be any. Unless James and I have been incredibly informative and covered every possible answer there might be already, which is a potentiality.
Yeah, whilst there's a number of participants watching, no questions are coming through. So as Will said, there's that opportunity to provide feedback through that survey around some of the data information we've shared today.
James, do you want to just bring up the slides again? Because there's one last thing to cover off after the survey. So there is that survey link. Well, one quick note on that. If you have participated in this project already, we would love you to fill it in. If you do know of anybody that you think would like to have a say in this and provide some feedback and insights, we'd love them as well. It is really, really crucial as part of this co-design project that we get as many voices in the room as possible. It is being designed for the Far West LHD specifically, and so it needs to have the voices of the Far West people. So please spread that link far and wide. We'd love to get as much feedback as possible. And then in terms of next steps, if you could, there we go. So we have accomplished quite a lot in this LHD already. We have been trucking along at a clipping pace, getting through quite a lot. Number of sessions with experienced participants, a number of sessions with health professional participants to get us to this point. We have a bunch of data and insights, observations to read through and to collate. We are now at the stage of the feedback loop number 1, which includes this webinar. We then have survey questions available, so that survey link, which we'll also be sending out. And then once all those surveys are completed, we review the feedback, questions, ideas from that. That allows us to further refine the designs for the safe space we have now. We then move into the health professional session 2. So we look at the lived experience outputs from the previous stage of the project, and we start to review, well, what are the ideas, the insights from that process. We then have feedback loop 2, which is much like today, sort of an update on the homework we've been undertaking, the process of the project so far, before jumping into a joint stakeholder session 3, which is a coming together of a lot of different voices and perspectives of the project. Finally, we then wrap up with another session like today, the final feedback loop to provide, well, showing back where the project is at, the ideas, designs, concepts for that safe space, survey questions, and a final review of those documents. So through every step of the process, you will get a check-in with where we're at with the project, the ideas and the concepts that are coming out of it. It is a very much an iterative process. There's quite a lot to do yet from here. But we are, I think, getting through it really, really well. And I do actually want, at this stage, really want to reiterate just our gratitude in this project. James and I aren't from Far West. We've been welcomed into the community to help facilitate this project. And it's been incredibly welcoming, incredibly passionate people we've had in the project so far. So hopefully, if you're not sick of us by the end of it, we can't wait to continue working with you. And thank you for participating in it and being so generous.
Yeah, well said, Will. And I guess in a timing of that next steps, that's over the next few weeks, isn't it, Will, in terms of wrapping that up?
Correct, yes. So the next few weeks, there are some dates that will be sent out for the next sessions, but all the current participants have invites on those particular sessions and login details already.
Wonderful, thank you. And thank you again for those that are joining today, but also thank you again for those that put in the time, energy and effort to give us that feedback or that data to date and hopefully continue this journey with us in the process, which is no doubt going to be a fantastic outcome. Thanks again. Thanks for your time, Will. Thank you everyone out there, and be safe and see you again soon.
Thanks everyone.